The one thing that it seems to me there's always to be important to remember is that actually integrated care is what it's about. I do think there is a danger of kind of jumping to structural or process solutions without starting at the very beginning and remembering that it is what the patient experiences that really matters. This isn't necessarily just about clinical pathways, because actually having an integrated a sense that the administrative system with which you are dealing is integrated can be just as important for patients as feeling as if your care's joined up. Some people, the minute you talk about integrated care, only start to think about integration of health and social care. Others instantly jump into integration across primary and secondary care. Others jump at integration across a different range of providers. And I think it's important that we keep all of those in mind, because actually the patients who need our services, our care, not our services, to be integrated the most are almost certainly those who have multiple problems and are therefore likely to come into contact with health, with social care and with all the aspects of health. So we need to think about what are the different ways that provision can work in order to give integrated care. There will never be one size fits all, because it may be simply that actually a range of different providers actually deliver their care in a way that there aren't the gaps in between this. People are starting to say, well, actually is integrated care about having a set of providers who work in a network with one of them actually kind of being the lead contractor? Is it about providers having pooled budgets? Is it about providers joining together to create one organisation? What can commissioners do in order to achieve this? And again, I think there are a broad range of things that commissioners do. It can be about one commissioner actually identifying the way that it commissions care and the way that it specifies care in order that it feels more joined up for the patient. In the same way as integrated provision is sometimes helped by pooled or shared budgets, then actually we need to see integrated commissioning. This won't always be about one commissioner who deals with one specific aspect, and we need to make sure that commissioners in the way they behave understand how they can, by integrated working, provide better integrated care. There's absolutely three things fundamental to what we're trying to do at the moment. The one is put the patient at the centre of everything we do. The second is to make sure that we focus much more on outcomes and not on process. So it's completely and absolutely about outcomes, but remembering that outcomes include patient experience. And three, that we actually give clinicians much more of a role because of their intimate knowledge and understanding of their patients and their relationship with their patients, much more of a role in defining what care should look like. And a lot of people over the last few months have sort of said, well, why GPs, why GP practices? It is the GP practices which are the core of the way we deliver NHS services in England. They coordinate virtually all the care for their patients, but it doesn't mean that they do it. And the same applies to when practices come together in a clinical commissioning group. They are the coordinators of the care, but it doesn't mean that the coordinators of commissioning, but it doesn't mean that they do all commissioning, because all that good commissioners do is bring together all the people around the table who have a legitimate knowledge, interest or understanding of how we can make it better for patients. So I think we have a unique opportunity, because instead of just having the benefits we've had of the GPs as providers with that registered list, they now have an enormous opportunity to influence the totality of care of their patient. And I think that they will be very good at doing that. They know a lot about their patients. For the most part, they relate to a specific population. They are professionals who will therefore hopefully be able to work with the other professionals, whether health or social care, to create these new pathways. They should, I would hope, have the confidence of the public, because actually in order to get really great care which is done in a different way and which is integrated, we probably need to be less wedded to buildings and more wedded to where the care can be delivered for the patient that's appropriate. And also, I think finally, and more than anything else, they actually see on a day-to-day basis the results of when care isn't integrated, and the problems that then creates for their patients, and frankly sometimes creates for them. So I am, as you will see, really optimistic that the potential for clinical commissioning, provided it is the broadest of clinical commissioning with general practice acting as the coordinator, and ensuring that clinical professionals understand and remember always that actually they can sometimes speak for patients. I think that we've got an exciting platform on which to move forward, and I think looking at some of the things that are happening around the country already, where clinical commissioning groups are working with their local health and wellbeing boards, then I think those are the places where we're beginning to see a real population focus and a real ability for the people who live on that patch and the professionals who look after them to actually make the difference that I guess everybody in this room wants to see, otherwise you wouldn't be here. Thank you.